Okay, good afternoon, everyone. I'm Kate and this is Mackenzie, and today we are going to be presenting on the history of occupational therapy's role in neonatal care. So, as we look at the history of occupational therapy's role in the NICU, we have to consider that OT only really recently became involved in this setting. So, to execute our historical analysis, we began the early stages, which we consider the founding years, 1910s to 1970s, by examining just the general practices of neonatal care providers, including nurses and doctors, throughout this time period. So, when we look at the 1910s, a very important area that we saw was the emergence of new technology and specialization. So, in particular, the use of incubators at this point demonstrated that premature infants could survive their infancy into later time. And so that this was an area that indicated that we need more medical care for these populations. When we're looking at feeding during this time, there was a large focus on what should be fed to the infant. So breast milk was considered the best option, but they did often use cow's milk that was modified because at this point formula hadn't been created, so it wasn't available. And they also did occasionally use wet nurses. Sensory motor development was also important, and nurses were instructed in very specific carrying and handling techniques for infants because providers were concerned with overstimulating the infant at this point. Parent education was also incorporated into practice and continues to be a trend throughout all of neonatal care. And this included educating parents on breastfeeding techniques, as well as how their behaviors, such as drug use and other dietary behaviors during pregnancy, could impact their infant. So in the 1920s, we'd see further specialization in neonatal care. So practitioners are becoming more concerned with outcomes for this population because they are surviving their infancy. And so maternity and infant hospitals were established in order to prevent premature births and decrease the neonatal complications that were associated with mortality. Parent education also continued to be very important. So providers were focused on educating parents to observe their infants and read their cues so that they could respond appropriately and provide care. Sensory development at this point became focused on thermoregulation as one of its areas, and practitioners and researchers looked at the use of oil bathing to help infants maintain their body temperature, and they actually linked this to reduced weight loss, although they weren't really sure why at this point, and more research was done to look at that later in history. So in the 1930s, we see further specialization of care in that researchers are starting to identify more outcomes and other information related to the premature population. So one researcher identified what she referred to as prematurity syndrome, which was associated with a short attention span, shyness and overdependence, high auditory and visual sensitivity, and poor fine motor control. And she credited this to the overcompensation by parents for the minimal stimulation that the infants were receiving in the initial period of their life. So parents felt that because their infant was in the nursery and hadn't had much interaction in their very early stages, they needed to then provide more stimulation. And researchers actually saw this as problematic because the children were then getting too much stimulation and they were overwhelmed. So when we look at feeding at this point during the 1930s, we're no longer concerned about what we're feeding the infants, we're more concerned about timing. So waiting to feed the infants, as far as some providers and researchers were saying they should wait at least 12 hours after birth because we're going to help prevent certain problems that can be associated with increased mortality, as well as the progression of feeding. So if an infant was being fed via a tube, how do we transition them to then feeding via a dropper and then a nipple either on a breast or on a bottle? And then lastly, sensory motor development during this period. Providers and researchers understood that the infant has a poorly developed nervous system. And because of that, they were looking at minimizing the amount of handling that the infant was getting in order to prevent them being overstimulated. Then in the 1940s, again with specialization, we are now given a clear definition of prematurity, which is infants weighing less than 5.5 pounds at birth. And with that comes special nurseries and special equipment that needs to be used for this population in order to provide proper care. When we look at feeding now, it's not only seen as a way for the infant to get nutrients and sustain life, but also as a means to promote that maternal infant bond. And then lastly, with parent interaction and education, involving the parents in care starts to emerge as a trend. So the parents become involved in providing care even in the hospital setting, because this is going to prepare them for care at home and allows them to take responsibility of the infant as their own.
So in the 1950s, we're seeing parent education again and the incorporation of parents in the care of their infant. Health professionals are teaching the parents how to care for fragile babies to instill confidence so that when they take their infant home, they can safely care for their baby. So we're educating on what the baby looks like and how to tell when something's wrong. And these combined will provide a safe home environment for the baby, instill confidence in the parents, and create a better parent infant bond. With specialization of care, prematurity was continued to be something that health professionals looked at, and how negatively it can impact infants and how development can be impacted. And so they started to look at risk factors for prematurity to prevent it. And they found that the mother's physical appearance and physical condition, nutrition, and number of pregnancies either heightened the risk or lowered the risk for that mother to have a premature infant. With feeding, discharge became the ideal and what we wanted the infants to do. And it research started to see that when the infant reached their maximum sucking rate, that was associated with sooner discharge. In the 1960s, we're now looking at the sensory external environment. Babies were in the mother's uterus for a long time, and that is a very dark, warm, safe area. And when they're born, they're in this extrauterine environment that's not conducive for them. It's very loud and bright and overstimulating and can negatively impact development. So it became important for nurses to promote that parent infant bond to try and mitigate that negative impact on development that the external environment has. With feeding, they're now continuing to look at the timing and debated whether early nutrients to the baby was better or if they waited just a little bit and made feeding safer to prevent regurgitation and edema. They debated which one was better. And they also looked at the maturation of suck and further explored how that can be an area to address in therapy and as health practitioners in order to get the baby discharged from the NICU. In the 1970s, parent interaction and that bond is explored more, and we're looking at the parent side of things. So a premature birth can be very emotional for parents. They may grieve a normal birth and they may have to cope with it. So we're helping mothers bond and become more comfortable with what the baby looks like in order for them to actually bond and for the parents to feel like a true parent. With specialization of care, we're now using corrected age, which is the chronological age of their infant minus the number of weeks born early the infant was. And this allows health practitioners to better compare the development of the premature infant to a full-term infant to see where their development is. Within the sensory systems, we're looking at how to incorporate parents in reducing the infant stress. So infant massage and gentle flexion help to decrease stress and develop sensory systems within the infant. And then parents were brought in and taught how to do that so that they can have a more control over what their baby does, increase the bond between the parent infant, and have better development in their sensory systems.
Okay, so as we come into the 1980s to the 2020s, which we consider the digital age of practice, we're now seeing the emergence of formal occupational therapy services within the NICU. So occupational therapists are now entering into this setting, and they're taking on a lot of the intervention efforts that had been previously put in place by nurses at this point. So in the 1980s, one important area that we are continuing to look at is outcomes and prevention, and OTs that enter the NICU setting are very focused on early identification of infants who would potentially need services in order to remediate any potential delays that they might have or reduce the amount of disability that's going to be associated with a condition that they have. Feeding, OT proves itself to be effective by studies showing that OT services were able to increase the sucking rate by addressing oral tone and sensation in premature infants. So OT is now showing that they are very useful within this setting and that they're cost effective because, as Mackenzie had mentioned earlier, that maturation of suck and increasing the sucking rate is associated with discharge, which is ultimately our goal, especially when we're looking at third-party payers. When we're looking at sensory motor during the 1980s, the emergence of positioning is now, as a sensory intervention, is now being seen. So using positioning, occupational therapists are able to provide the infant with sensory stimulation without overstimulating them the way that they may if they were handling them. And this is really important. As we have seen, overstimulation in the NICU is associated with certain processing issues later on, so it's important to reduce that. And this new understanding of stimulation within the NICU is in alignment with some previous understandings that were seen throughout the founding years that focused on minimizing handling, but is also in contrast to the concept that was identified with prematurity syndrome, which was that the infants received minimal stimulation during their time in the neonatal care unit and then were then overstimulated by their parents. However, in both, we do see overstimulation playing a significant role. And then as far as parent education and interaction, occupational therapy is now taking on that role of helping involve parents in care and getting them incorporated in the infant's care routines. So in the 1990s, we continue to see the emphasis on outcomes and prevention. So early services being provided is very important at this point, and this aligns and coincides with the creation of early intervention services through IDEA Part C. So OTs are looking at providing services as soon as possible that are tailored to that specific infant's needs. When we're looking at feeding, we see that there are new stroking and oral motor protocols that emerge thanks to occupational therapy, and these help to decrease the length of stay, which is then really great with the economic pressures to discharge as quickly as possible that we're seeing during the 1990s. As far as parent interactions and education, during the 90s, we are finally seeing the emergence of kind of what we see as a formal family-centered care model as the standard for NICU practice, and this continues through the 2020s and is still very relevant today. So with that, we're looking at eliminating that power differential between the occupational therapist as the expert and the parent, and allowing the parents to really take responsibility for their infant's care. With sensory motor, we see that practitioners are using Al's synaptive theory to help explain infant states and to be able to properly interact with the infant based on their cues. So identifying stress signs becomes very important at this point. And then as far as the environmental impact during this period, we're now not only looking at the fact that the overstimulation due to the NICU environment is problematic. Occupational therapists are figuring out ways that we can adapt and prevent those problems from happening. So as we move into the 2000s, please bear with me, I could not find my clicker. As we move into the 2000s, we see that sensory motor wise, we're now looking at positioning as a means for self-regulation. So positioning the infant such that they can bring their hands to midline to be able to self-soothe and do other things similar to that becomes very important. And that kind of helps us to see that there's a relationship between sensory motor stimulation and interaction and behavioral states. When we're looking at the environment, we see that providing changes to the environment and allowing for family-centered care helps to reduce the impact of the sensory motor experiences that the infant has on their ability to develop properly. And then with parent education and interaction, we're looking again at really solidifying that family-centered model. So occupational therapists are treating the entire family as their client, not just the infant alone. And they're often using co-occupations, so involving the parent in feeding, in changing the infant's diaper, in order to promote a feeling of a typical family experience, which is really important in promoting a bond between the infant and the parent, and in preparing the parent for the infant to come home. The 2000s, we are now finally seeing the initial recognition of the impact that stress and pain has on infants in the long term. So prior to this, it was actually believed that infants could not experience pain, and now we are finally looking at the fact that infants can experience pain, and not only can they experience pain, their experiences of pain have long-term impacts on their function.
So in the 2010s, parent education continues to be one of the major areas that occupational therapy is going to address, but we're going to address it in various different ways and continually throughout the therapy processes. Parents are taught various different ways on how to care for their child. So one-on-one in therapy, the OT is going to incorporate and educate them. In group settings, we're going to teach them what to expect and how to interact with their premature infants. This also provides support from other parents. We're also going to give handouts that they can look at when they go home, they can reference very easily. We're also promoting skin-to-skin contact to reduce stress and promote bonding. So once again, incorporating the parents and promoting the bond. Parents were involved in treatment and taught to do most things and should be the primary caregiver for their infant. This promotes bonding and reduces the stress and promotes confidence in the parents for safe return to home upon discharge. Within the environment, like Kate said, we're adapting to prevent stress and pain in this external environment that they're not used to. So we're dimming the lights, we're reducing the noise, we're reducing the visual movement that they're seeing, and we're trying to provide cluster care in order to decrease the amount of painful experiences they have in the NICU. Because, as we said before, the NICU is a very painful place for the infant to stay. They have painful procedures. They're often overstimulated and they're not ready to feel what they're feeling. And so with pain comes increased stress. With increased stress comes negative impacts on development. So in this era, occupational therapists started to assess pain in the NICU by looking at the infant's stress signals and their sleep awake states to determine just how much pain the infants are in. And now in the 2020s, in the current decade, we're continuing to look at parent education and the incorporation of family-centered care. Being in the NICU and having a newborn that was premature is very overwhelming, and it can cause grief and cause the parents to need to cope. And it can be even worse if they're not incorporated and not educated in what to do with their baby. So our role as an occupational therapist is to come in and reduce the parent stress through education and increase that parent bond. And we're educating them on what to expect. You're going to expect tubes and monitors everywhere, but that's okay because it's helping your baby grow. We're going to educate them on what the baby can do and what they're going to look like. And we're going to look at what daily occupations they're going to see their baby do and what they can do together. With stress and pain and the significance on development, we're coming in and we're trying to make reducing that a priority. So through history, we have found many different ways to do this, and this is through the smell of mom's breast milk, through mother's heartbeat, through the use of non-nutritive suck, through infant massage, through facilitated tuck and specialized positioning techniques to bring to midline. So throughout history, we've evolved and we've really learned that incorporating parents in the care of their child is important to promote that bond and reduce parent and infant stress.
So thanks for listening to what we had to say about NICU care, and here are our references. I don't know how to stop recording. Oh, wait.